Welcome to this Beyond Zero e-learning module as part of the Beyond Zero Complicated HIV and TB course. This is a module specifically for people who might have missed this session of the Wits RHI course on complicated HIV and TB. This particular session is going to be an introduction to understanding HIV treatment failure and resistance. So at the end of this particular session, I want to teach you some key concepts around resistance and a few of the key mutations. And we're not going to spend too much time on a lot of theoretical definitions, but on those ideas that can help you better understand HIV treatment failure. So let's first start and just recap on how HIV resistance to ARVs develop. But it has to do with this interesting biology of the virus that we covered during the virology session. So remember, our viruses are replicating at extremely high rates every single day. And because it's going from RNA to DNA through reverse transcriptase, remember we're going from the 3D printer back to the actual pattern, it can make lots and lots of mistakes, and each one of these mistakes creates a mutation. And in the vast amounts of millions of mutations that get formed every day, some of those mutations have the potential to be resistant to specific ARV drugs. So this is what happens in practice when you then use ARVs. So all the time that replication is happening, mutations are happening, but a lot of these mutations don't survive because they are being overwhelmed by the blue there, which is your wild virus. Your wild virus is generally tougher than the mutants that are busy forming. But if you are taking ARVs and you take your ARVs well, then all of the virus gets wiped out, your viral load becomes suppressed, and no new mutations can form, and the few mutations that were there had no chance of surviving. But say you take some of your treatment, but not quite enough. So now what happens is there's enough treatment that it actually kills off most of the wild virus, and it gives those mutants that might be drug resistant, it gives it a bit of an unfair advantage to start replicating. And so over time, you will have more and more of these mutations replicating that are resistant to the virus, and the little bit of drugs you are taking is actually managed to clear the wild virus out of the way. So the bottom line is simple. To be able to form resistance, you need suboptimal drug levels in your blood. So if there's some ARVs in the blood that can wipe out the wild virus, but not enough to suppress you completely, you're going to have viruses replicating and you're going to have more mutations forming. And there are lots of factors that contributes to you not having quite enough ARVs in your blood. Of course, the middle section there is very much to do with adherence. This is the one we focus on the most. But there are other factors that can influence those drug levels, including drug interactions. And we also know patients who start on ARVs and are quite sick, so have advanced disease, low CD4 counts, high viral loads, they have a higher risk of failing. And then, of course, we can also actually be infected with a drug-resistant virus in the first place, which means your ARVs will never be able to completely suppress. But we will look at a more practical approach when you actually have a patient in front of you with antiretroviral failure. So when we speak about HIV resistance, we're actually always talking about adherence, and we won't be covering adherence in this particular session. But that is the biggest challenge with ARVs. If you take your ARVs 100%, from the moment you start, you will have complete viral suppression, and HIV resistance will never become an issue. And we are therefore relying on patients being able to take their treatment every single day for the rest of their lives for them to be able to have a successful treatment. This is a nice, interesting slide, which we don't always take into consideration, that shows how the viral load of the patient, so how high the viral load is, does contribute in how quickly resistance develops, because obviously the more virus there is, the more mutations will develop. So right at the bottom there, you will see that if your viral load is 30, which is pretty much almost lower than detectable, very little bit of virus in your blood, it can take as much as 3 years for new mutations to arise. And that mutation is not necessarily going to be a drug-resistant mutation. So your chances of getting mutations if your virus is suppressed is extremely unlikely. But as soon as the viral load starts to increase, you can see if it's 300, which we'd still consider a very low viral load, every 100 days a new mutation might come about. But by the time your viral load is 300,000, so your higher viral loads, you can see every 2 hours new mutations are developing. And then it just becomes a matter of time before the wrong mutations or the mutations that have drug resistance possibilities is going to arise. And therefore, if you've got patients where the viral loads are starting to, they've been unsuppressed for quite some time, the viral loads are running quite high, there's a very good chance that they've already developed those resistant mutations. So I would like to now go through a few key concepts, and we're just going to cover 5 important ones that we will use often as we speak about genetics and mutations. And we'll start off just getting a little bit of terminology going. And when we look at the genetic code of the virus, to describe the mutations, the geneticists have this lovely language that they use, and it's made up of a whole lot of abbreviations. And this is just to show you that the abbreviations actually represent amino acids, which form the basis of these codons or these codes that we have on our DNA and our RNA. And you can see that, for example, M stands for methionine, V stands for valine. We'll come back to those two when we show you how we actually describe our. So this is just to show us a little bit how mutations are formed. And you can see here we have this is our pattern that we would find on a DNA or RNA. And on our DNA and RNA, we have these little three triplets of nucleotides that was going to correspond to make a specific amino acid. And these different codons makes up our genetic code. And there's lots of different combination of these 3-letter nucleotides. Now, if these nucleotides are either replaced by a different nucleotide, or a new nucleotide, a new set of codons is inserted, or a whole set of codons is actually deleted, it is going to change the amino acid that is going to be expressed at the end of it. So this is how the geneticists describe these mutations that then form because there's now a different amino acid than there's supposed to be. So the codon position is number 184, and you can see there's an M at the beginning and an M at the end. And this means that there's a methionine that's supposed to be on codon position 184 in the normal HIV virus, and it does have a methionine in that position. But if you have a mutant, you can see the M on the beginning. There's what you would want to see for a normal HIV virus. That's the wild-type drug-sensitive virus. It will have a methionine on that position. But in this particular mutation, there's actually a valine amino acid at that position, and that is your mutant. So they all have these names, and the M184V mutation makes the HIV virus resistant to lamivudine, and we'll come back to this very interesting mutation. So let's get now to our key concepts in HIV resistance. And I'm going to be looking at 5 of those: types of resistance, genetic barriers, something called the zone of replication, a little bit about viral fitness, and cross-resistance. Our first concept is around primary versus secondary resistance. I think this is a fairly well-known concept. Primary resistance is when we've actually been infected with a resistant virus from somebody else. Induced secondary resistance is, of course, when we ourselves have not taken our treatment well, and the virus becomes resistant as described in those first slides in this presentation. What we're not entirely sure about in South Africa at the moment, and we don't yet have good enough data, is what is the rate of transmitted resistance in South Africa. The number often quoted is about 5%, but that is certainly out of date. And also it's very possible that there's very different patterns of primary resistance in different parts of the country, and we certainly need more information on that. But South Africa has still relatively low transmitted resistance in comparison with the rest of the world. And it has a little bit to do with the history of South Africa. This slide here shows the development over the years of coming to the conclusion that what we need is triple therapy to actually prevent the progression of HIV to AIDS. But in the beginning, when we first started finding treatment for HIV, we used mono and dual therapy. 1987, AZT first came out. And then what they discovered, very disappointingly, is that although the viral loads dropped beautifully when they first started patients on treatment, within a few months, and certainly by 2 years, the viral load would have crept right back up. 1994, they introduced dual therapy, and it was only in 1997 that they finally realized that we need combination of 3 different drugs to be able to get complete viral suppression and for viral resistance not to arise. And ironically, South Africa, the disaster of the very late introduction of ARVs in South Africa, we only introduced them in 2005. There was one very small silver lining, which was that by the time we introduced ARVs, we introduced triple ARV therapy. And there's therefore very few patients who has been exposed to either mono or dual therapy in the old days. And we therefore have a lower rate of primary resistance than the rest of the world. The next concept is an important concept and has actually been asked in the HIV diploma, and that's around genetic barriers to resistance. And basically, it has to do with the fact that not all ARVs are equal in the eyes of the HIV virus. So for the HIV virus to become resistant to a specific ARV, for some ARVs, it's very easy for the HIV virus to become resistant. All it needs to do is make one small mutation, and those we call a low genetic barrier. Some of those mutations form very, very easily, such as the case as with efavirenz and nevirapine, and other single low genetic barrier drugs, for example, it's lamivudine. For other medicines to become resistant, the HIV virus has to mutate several times. So that means it makes a mutation, and then has to mutate again, and then it has to mutate again, and it has to have several mutations to actually become the kind of virus on which that drug is not going to work. And this is what happens with our protease inhibitors, our boosted protease inhibitors. It's got a very high genetic barrier. It's actually quite difficult to get resistant to those drugs. This is a lovely slide that gives a little bit of a picture of most of the drugs that we are very familiar with. And you can see right at the bottom there, with the lowest genetic barrier is our efavirenz and nevirapine, our NNRTIs. Easily forms a mutation. Lamivudine, also relatively low genetic barrier. Tenofovir and abacavir, both first-line drugs, is there on the low intermediate side. They also need single mutations, but these mutations takes slightly longer to form. And you can see zidovudine and savudine, some of our older ARVs, and zidovudine that we use in our second line, it's got intermediate genetic barriers. It takes a few mutations before we're going to lose those drugs. And then right at the top there, we have lopinavir, and specifically boosted lopinavir, darunavir, boosted darunavir. Takes a long time, takes years to become resistant to those particular ARVs. So that's genetic barrier. Next concept has to do with the zone of replication, and it has to do with the pharmacokinetics of ARV drugs. So obviously when we take our drugs in, they have to be digested by the body and eventually excreted. And just a little bit of a pharmacokinetic slide there for you, just to remind us that when you take in any medicine or any drug or any food for that matter, there's an absorption phase of that particular medicine, and it will peak Cmax there in the blood, and then it gets eliminated over a period of time. And different drugs get absorbed and eliminated in different ways. What this creates is the possibility for different drugs to be at a certain concentration in the blood for shorter or longer periods of time. So we spoke earlier about the fact that you need just enough drugs in your blood to create the scenario where your viral load's not LDL, but also enough of the wild virus is being wiped out to give all these mutants an advantage to start replicating. And that ideal zone of ARV concentration is called the zone of replication, called the zone of resistance selection. So that particular blood level of blood is ideal to form a resistant virus against that specific ARV. And the challenge is when we are taking 3 different ARVs at the same time, is that it might be that they're all being digested differently. And that becomes important when you suddenly stop your ARVs or when you have to stop a patient's ARVs. So this example here would be a good example of, for example, drug A being tenofovir, drug B being lamivudine, and drug C being efavirenz. And you can see that efavirenz and virapine as well to some extent takes a long time to actually be digested or wash out of the body, and they can be in the body for as long as a week. And that zone of replication, therefore, can go on for several days, where your body might have enough ARVs left over in your blood to create this perfect zone of resistance selection, which is a disaster with efavirenz because you only need one mutation, the wrong mutation, to become resistant to efavirenz. This particular concept becomes extremely important when you decide to stop somebody's ARVs, and that is particularly in scenarios of drug-induced liver injury. So you have a patient who has developed jaundice, who might be quite sick, so we have to stop all their ARVs, and then we have this concept of what we call it covering the tail. So when you stop treatment, you've got to cover the tail of the efavirenz, this efavirenz that stays in the bloodstream for a week longer than the other drugs. And there's different ways of doing it. The easiest is normally to give Truvada for an additional 7 days just to cover that tail, or you can give Eluvia for additional 7 days. Most of the times when we are stopping ARVs, it's usually due to DILIs, and the drug we are the most worried about is the efavirenz. So Truvada can then be used quite safely. Our fourth concept is about viral fitness, and it talks to the fact that, which I mentioned earlier as well, that your wild-type virus is much tougher than your mutants. Your mutants are disabled, they grow slowly, and they don't necessarily damage the immune system as quickly. It's not true for all of them. You do have tougher mutants than others, but generally your wild-type virus always has the advantage when the patient's not on ARVs at all. And then the last concept that is an important concept in the world of resistance is cross-resistance. And this is the reason why we don't like keeping people on failing regimens for terribly long periods of time, is that while you're on particular ARVs, obviously the mutations are going to select for those specific ARVs that you are taking, but there can be cross-resistance. So certain mutations that will develop will also cause resistance to other drugs that you might not even be on yet. So, for example, the K103N will make you resistant against the efavirenz that you are taking, but if you were to use nevirapine in the future, the nevirapine would not be effective either. Another famous set of mutations we will be speaking about is the TAMS, the thymidine analog mutations. We will mention them in more detail in a minute. And there you have a cross-resistance between especially AZT, D4T, eventually then TDI, and eventually even abacavir. So if you leave somebody on a regime that they are failing on for a long period of time, you're going to end up losing some of the other ARVs you might want to use in future regimens. So now we're going to move on and actually talk about some key mutations according to the different art classes that we use. And you don't have to know every single funny mutation, but there are certain key ones that is important to know and understand. We'll start off by talking about our nucleoside reverse transcriptase inhibitors. And this is just a quick slide to remind us that our nucleoside and nucleotide reverse transcriptase inhibitors are based on particular nucleosides. And you can see there's our 4 main nucleosides at the top there. And I want to highlight the thymidine-based nucleosides, which is zidovudine and stavudine, because it's from there that the name of our most famous NRTI mutants come from, which is our TAMs, our thymidine analog mutations. And they are particularly famous for AZT and D4T, and the only one that's an exception here is actually the 3TC. And with AZT and D4T, if you remember when we spoke about genetic barriers, we said that it's not that quick to actually get resistant to AZT or D4T. You need at least 3 or 4 different mutations that build on top of each other for that virus to become resistant to those particular ARVs. And therefore, when we are putting somebody, or for example, we've used monotherapy AZT in pregnant women at one stage as part of our PMTCT program, and we could actually use monotherapy AZT for a few months and not run into too much trouble. The challenge is that over time, these TAMs then confer cross-resistance. So if you're on AZT and you make 1 mutation, 2 mutations, 3 mutations, 4 mutations, so eventually you become resistant to the AZT. But more and more of these thymidine analog mutations will form the longer you stay on the AZT, and eventually you'll also become resistant to D4T. And then as time goes on, you will lose DDI, and right at the very end, and I must say this will be much later, you could even lose tenofovir and abacavir. And the more TAMs there are, the more resistant the virus is. Unfortunately, the AZT-resistant virus is fairly fit and virulent. It's not particularly damaged by all of these TAMs that are forming. The next mutation is one of our most famous and most beloved mutations, which is the M184V mutation, and it's a definite must-know. And this is the one that gives resistance to 3TC and FTC, so lamivudine and amitriptyline. But it can also give resistance to a lesser extent to DDI and abacavir. If you've got M184V plus TAMs, that can cause significant abacavir resistance. So that might be an issue in a child that, for example, was on D4T and 3TC based old regimens for a long time and might have lost both those regimens. You might also then have a problem when you introduce abacavir into your second line. But what's interesting about the M184 virus is that when the virus forms this mutation, that particular mutation is a very weak, crippled mutation. And it actually makes it easier for other ARVs to kill it. So if you have the M184 mutation, it makes it easier for AZT, for example, to kill that particular virus. So it reduces viral fitness, it reduces viral rebound. And it also therefore protects against further TAMs even forming. And this is the reason why we see that our 3TC and our our 3TC specifically and FTC can be used in our second line regimens, because we want then to select this M184 mutants because they're so much easier to destroy. And there's a nice little slide which shows that if you were to put somebody on 3TC monotherapy, although the viral load is certainly lower than it would be, they don't replicate as well if you weren't on any ARVs, but that particular virus actually is also going to cause much slower progression. And there are scenarios, in particularly adolescents, where 3TC monotherapy or holding therapy has been used in the past to give people a bit of a break between first line and second line. This is very much becoming going out of fashion, simply because we don't actually like too much immune destruction happening, and even on 3TC your immune system will slowly also be affected by the viral load. So if you are considering something like 3TC monotherapy, you will only do so under the guidance of an experienced pediatrician. Our next mutation we would like to talk about, so we've done our thymidine analog mutations, we've talked about M184V, and now we want to talk about the K65R, and this is also, again, just one mutation that needs to form, and that is specifically cause resistance against tenofovir. but can also have an effect on Abacaba or DDI. And what's really interesting is that the K65R mutation is more sensitive to AZT and D4T. So there's this interesting reciprocity or usefulness in terms of being able to use your AZT and D4T more effectively if a patient is resistant to tenofovir. And it does reduce viral fitness and replication to some extent. And there's this offset between thymidine analog mutations. Actually, you become less resistant to your TAMs if you've got the K65R. So AZT, therefore, is an excellent choice for second line if you are resistance to tenofovir. This gives a nice table to show how these drugs can affect each other. So you can see how a mutation like the K65R, which is selected by tenofovir primarily, to a lesser extent Abacaba and DDI, but will increase susceptibility to zidovudine. And when we have our results from our resistance testing, they actually give a score for every drug on whether susceptibility is increased or decreased depending on the kinds of mutations that are found in that particular HIV population. Right, so that's all our NRTIs, and those three you need to know about, the TAMs, the K65R, and the M184V. We now want to look at efavirenz and nevirapine, our NNRTIs. And as mentioned when we talked about genetic barrier, these are a disaster. Resistance develops very, very quickly if the HIV is not suppressed effectively. And all you need is a single mutation, again, and you've already lost your other NNRTI. So K103N very strongly selects for efavirenz, and there is some cross-resistance to nevirapine. And the Y181C very strongly selects for nevirapine. And so the last class we want to chat about is the protease inhibitors. And as we've mentioned with genetic barrier, protease inhibitors have got a very high genetic barrier. And you need several mutations over time to actually become resistant to your protease inhibitor. Firstly, it will be the one that you're on. For example, the lopinavir ritonavir that you're taking. Unfortunately, this damaged virus is harder to replicate. So if you start forming mutations, those mutations don't actually replicate so easily, and so more mutations are even more difficult to form. There is cross-resistance eventually to other protease inhibitors, and those mutations might again improve the viral fitness, unfortunately. So how do we test for resistance in our patients? And I'm just going to have a single slide on this. We're not going to go into this into very much detail because we standardly use genotypic resistance testing. At the bottom here you can see phenotypic is the one we're more familiar with when we're doing our MCNSs on our patients for bacterial infections, for example, where they'll actually take the organism, grow it in a little petri dish, and then check which antibiotics has an effect on those. It's a very direct way of testing it. And that's a very, very difficult procedure when you're dealing with viruses. And is not practical, very expensive, and is not a very good way of testing for resistance in the HIV virus. So what we've done is we've actually got an indirect way of doing it. And we take a blood sample of the patient, and what we do is we sequence the virus. So we do a genetic sequencing of all these codons, and we're able to therefore then create a list of all the mutations that this particular HIV population has. And then they take all these mutations and they put it through a very, very clever mathematical database. We like to use the Stanford database. And this database will then look at, remember I said each mutation can either cause resistance, but can also make other ARVs make the HIV more susceptible to some of the other ARVs. And they take all of these different factors and they will work out for you and print you something that looks very similar to a phenotypic result of saying there is no resistance or intermediate or high resistance against a specific ARV. Genotyping is expensive, so there's very specific rules around when and how we can use this to detect resistant patterns. Because of this way of test using the genotype, this can be affected by a wide variety of things. And one of our biggest challenges with genotyping is that you have to take it at the right time. So if somebody defaulted on their treatment some time ago, you're not going to be, it might be more tricky to find out if they have resistant viruses, because if you're not taking your ARVs, remember the wild virus is much stronger, so the wild virus is going to be replicating at much higher speeds. And although there will still be these resistant mutations there, they might not be in that particular sample that you are taking. And it will only become visible once again when you take that particular ARVs and then the wild virus is wiped out. So there, you cannot take a blood sample on somebody if they're not on ARVs or haven't been on ARVs in the last 4 weeks. And also you need enough virus to be able to do the genetic coding. And normally we say you need at least 1,000 copies. The viral load must be over 1,000 or over 500 at least for your genetic testing to be useful. So in summary, understanding the mutations in the HIV population helps us to understand resistant patterns and make better choices for better ARVs. Do see our next e-learning module on an approach to treatment failure to put some of these concepts into practice and to show how we can approach a patient who is presenting with biological failure. Thank you very much to Wits RHI for the material, PEPFAR for our funding, and some of the slides from South to South.